باسمي وباسم القائمين على هذا المؤتمر وباسم كافة طلاب كليات الطب الأردنيه في الجامعات الأردنيه كافة، نتقدم بأحر التعازي والمواساة لفقيدة الوطن الدكتورة ميرونا عصفور، ونتمنى أن ربنا عز وجل يرحمها برحمته ويدخلها فسيح جناته. أرجو الوقوف مرة أخرى دقيقة الصمت عن روحها وقراءة الفاتحة عن روحها الطاهرة إن شاء الله. الله يرحمها ويصبر أهلها، وإن شاء الله يعني ربنا ما يبتلك هذا بالخير أحسن. فيديو الآن مقدمة نعرض لكم فيديو. طيب.
Okay. Assalamu alaikum. Now we will start with a distinct neurosurgeon, Professor Abdulla is a consultant neurosurgeon in Jordan University Hospital and specialized in skull base and oncology. Was graduated from London University in Sweden. Dr. Abdulrahman is a member of international membership of WANS and Pan-Arab Neurosurgical Society and member of WFNS, World Federation of Neurosurgery. He is welcome.
ثانك يو. صباح الخير جميعا. بداية أشكر الأستاذ الدكتور محمد البربراوي على دعوته لهذا المؤتمر. صحيح إني مبسوط بوجود عدد كبير من طلابنا، وهذا الشيء اللي بيفرح القلب. فنتمنى النجاح لهذا المؤتمر الأول وإن شاء الله يستمر وأن يكون هناك ديمومة. أؤكد يعني تعزية الحارة لزميلتنا في الجامعة الأردنية الدكتورة ميرونا عصفور التي انتقلت إلى رحمة تعالى يوم الخميس. إن شاء الله مأواها الجنة والله إن شاء الله يرحمها. بالبداية أود أن أشكر أيضا المسؤولين عن نيوروبيديا الدكتور عمر أبو جبارة على هذا التنظيم الرائع. My talk today will be about new technology inserted in our introduced to the country during last year, and it is the advanced technology in this field, which is the stereotactic radiosurgery. And this experience, at the end of this presentation, I will give some lessons from this project. I call it a project because it started 5 years ago. Then before 1 year, we have started our service by this technology. This is our technology. This is the Lixel Gamma knife, which is the icon. And this is the 6th generation of this machine. The first generation started in 1967, the first stereotactic procedure done by Lars Lixel, and then started other generation, and we have now the last version of the generation, which is the icon. This machine started and invented in Sweden by Professor Lars Lixel, and started, as I said before, 1967. And the project started in Lund University, then they shifted the project to Karolinska in Stockholm. So this guy, who was the father of stereotactic radiosurgery, Lars Lixel, started, as I said, and the machine at the end, before his death, became like this. And this machine, when he operated it in 1986 in Karolinska. So this is the primitive machine for the gamma knife. My story with this project started in Skåne University Hospital in Lund in Sweden. When I did my training and my PhD between 2009 and 2012. My mentor was one of the students of Lars Lixin, so we worked together in London University, and the passion and motivation for this project started at that time to bring this machine to our country, and this is one of the lessons I want our students to learn, and then they can, in their practical life, they can apply. So what we mean by stereotactic radiosurgery is concentrated or focused beam of cobalt-60 to a precise area in the brain, and this beam is originated from cobalt-60. Then we have 192 beam as this machine. This is just a simplification of what is going on. And this machine is just to give a high dose of radiation therapy to the target without harming the brain. Almost with the new machine, it is zero harm to the brain. So this is the concept just to the student in a simple way. What are the components of the machine? As you see here, it is there is X-ray tube, there is a patient positioning system. This is the component of the new machine, not the primitive machine. This is the advanced machine. So we have new things: the generator, the APS or the patient positioning system. This is new, and we have the high definition motion management system. هلا بنحكي عنه انه بيحدد اذا تحرك المريض بيعمل كوركشن للدوز وكوركشن لللوكيشن لانه this is a new software in this machine. Integrated stereotactic CBT اللي هي الكون بيم CT scan during you can modify your treatment during treatment according to the patient condition or a new new changes during treatment. So this CBCT will help you in modify your management without returning back the patient to the MRI and doing the new MRI, and this is one of the advancements of this machine. What are we usually do in this? We have two options in this machine. We have the old technique, which is the frame-based, and still we use it, and this is the most of the cases, frame-based workflow and frameless workflow. الفريملess workflow المقصود فيها إنه إحنا بنعمل mask without pins, without fixation on the head of the patient. So in the first case, the frameless, which is the mask. This is the mask. This is bad. So we have in this technology, new technology, the frame-based and frameless-based treatment. Frameless, we use the mask. كمان؟ لا رجعنا لحادث بطل يشتغل. So we start usually by the MRI, sending patient to MRI, then application of the mask. The mask is a special material. We put it in the face with the fiducials. Then we send patient to the CBCT scan. Then to do the plan. The plan is the most important part of this procedure. The plan, we mean that the neurosurgeon and physicist and sometimes radiation oncologist, which is a teamwork, should do or establish the dose for this patient and how many sessions, and this is the most important and critical step in treatment by gamma. After getting the MRI and detecting the target, the volume of the target, nature of the target, then we can determine how many doses we will give and how many sessions and the time and everything, with the help of the advanced software available in the machine. So we, then after plan, we send patients to the CBCT to make sure this is a real plan. Then we do the evaluation of the dose. What we mean by evaluation of the dose is to detect the risk areas in the brain and to decrease the radiation effect on these critical area in the brain, like optic nerve, brain stem, and then evaluation of how many part of the lesion or target can take the maximum dose without harm to the brain. We have some indication and the criteria, which are the coverage, the Bedic index, the selectivity, all of it. We use it to reach the maximum effect with less harm to the brain. This is technical. I will not talk about it much. In the frame-based, we send the patient to the MRI, the same step, like without fixation, we fix the patient, then send it to the plan and do the management. This is the old or classical way. So we have two track different. Now, what are we treating with gamma knife? This slide I will talk just in a brief, because this is the part which maybe concern our colleagues in different specialties, especially in not just in neurosurgery, but we are talking about psychiatry, neurology also, because some indications are concern of psychiatry and oncology and neurology and neurosurgery. Actually, this is the statistics from the source of the company. It's denotes that benign tumors, how many cases, and the increase from year to year, which reflects how is important and the technology now invading the field of neurology or neuroscience. Benign tumors increased during the last 4 years, indication by 24%, which is the most common indication now we use, especially for meningioma and vestibular schwannoma. Malignant tumor now increasing also because the metastasis. This is also a very good indication in this new machine. You can treat up to 30 metastases. A treatment means control of the growth. We have parameters for this treatment. In case of secondary brain tumors, we mean control of the growth of these tumors. In benign tumors, we mean by the treatment either regression or control of the growth. وبالتالي في عندنا عدة parameters للتريتمنت زي ما حكينا it's not within the scope of this presentation. في عندنا كمان functional disorders. We treat tremors, we treat trigeminal neuralgia, we treat some psychological disorders like OCD, obsessive compulsive disorder, and some psychiatric like doing either capsulotomy or cingulotomy. So we treated some of these cases now in this machine. Vascular disorders, we treat AVMs and cavernoma, mainly AVMs, especially some type of AVMs which are not amenable for surgical intervention or embolization, and some small AVMs which are in a liquid area, we can treat it also by gamma knife. So we have indication according to the size, Spitzer-Martin classification, so some indication, but it is also increasing. Other disorders, we have actually epilepsy, we have some orbital tumors, we have below foramen magnum now with a new technique up to C3. This talk maybe more can be understood by our colleagues in neurosurgery. So previously it is just to the foramen magnum, now we can reach C3 by treatment, especially with the mask technique. So it is blooming technology and increasing in use. So for this, now in summary, this is the case mix percent. So malignant 43.9 in 2019, benign tumor 39, vascular 10%, and functional targets 7%, but increasing the functional targets with the help of our colleagues, especially in cases of trigeminal neuralgia, neurology colleagues, psychiatric colleague, we can help in this. So this is a teamwork, and usually our cases, we discuss it in a team, in scientific committee, till reaching the decision whether this case go for gamma knife or not. This is the story. Then after that, after this, studying this technology, we did a study for the Jordanian population, as you see here. How many cases, this is the different type of cases treated worldwide, annual gamma knife cases per million, and real incidence, this is the real incidence, and the real indication, and how much can we, if there is a good system to pick up the pathology and a good referral system, how many cases per million or for the whole population of Jordan can be sent annually to the gamma knife unit. We reached, this is based on international data, not our data. So we reached that at least 3,500 cases should be referred to gamma knife if there is a good team and a good referral and a good system to pick up the pathology, I mean the diagnosis. So, and this done according to the worldwide data and the number of population of Jordan. So maybe some so what do we have now in the Jordan University Hospital? We have the first gamma knife in academic hospital on the level of the region, most of them in the private sector, and this is the target to serve people who are under insurance. We have this public insurance coverage. We have 2 qualified consultants, 2 medical physicists, 1 part-time, and we have 3 trained nurses. They went outside and come, and now we have established team in our unit at the University of Jordan. So now we are approaching, we have started our first case in end of last November, 29th of November, first official case. Before that we did 6 cases for training and to check up the quality of the machine. So now we are approaching case number 100 maybe next week. So we are working in a good way with the help of our colleagues in other centers. So it is also example of collaboration between centers and collaboration between colleagues with different specialties. This is when last winter, I think, February 2029, when the machine arrived and installed in the place. And this is one of our patients happy with this frame. This is the first patient we treated with gamma knife. And this is our team, Dr. Abdulla, nurses, physicists, and our visitor, Professor Martinez from Madrid. He did also a training course in our hospital. We have also the option of GA, general anesthesia, in our unit, and we have the option also for pediatric cases to do it also in our hospital. So we have a well-established unit, completely established. What's the lesson from this? As in this slide, keep going. Different roads, usual difficult roads, often lead to beautiful destinations. The message to our students that you should work in a team and collaborate with your colleague to reach something helpful for your country. When you go outside, bring with you either technique, knowledge, or technology to your country. Either technique, technology, or knowledge to your country. Every one of you can bring something to his country. So, I mean, you should have him during your going abroad and back to your country to bring something to your country. Please keep this in your mind. As we brought icon, we have also our Jordan icon Petra, and we have icon at Jordan University Hospital. Thank you very much.
We open the stage for 2 questions. I think it's better to ask the questions straight away after each session, not to leave it at the end of the whole session.
Yeah, go ahead.
One question? Yep.
It's Mustafa Ghazi. In those 100 cases that have been treated by this machine, have you noticed the difference in the differences in the outcomes or the goals that have been wished by you to be achieved by this machine?
Actually, we will report the results, the outcome of the treatment you need. We know that scientifically the outcome of the gamma knife starts after 12 months for some tumors, like the malignant, benign tumor 18 months, 24 months for vascular malformation. But trigeminal neuralgia, which is now we treated 18 cases of trigeminal neuralgia by gamma knife. All of them, the pain dissolved with incidence of 3 cases of dysesthesia. Trigeminal neuralgia, you can notice the outcome or the effect within 3 months. Regarding vestibular schwannoma, the second most common pathology we have treated, we have a 6 months follow-up, and after 3 months we will have 1 year follow-up. The 6 months follow-up I didn't show here because it started to have a good central necrosis. So the outcome is good, and we believe that after 1 year we will report the first outcome for this case.
And a good question. The surgical intervention it presents the immediate outcome, but for gamma knife it starts, as he said, after 6 to 12 months. My question the recent advances talking about brainstem lesions, the cavernomas and low-grade gliomas, which are not surgically applicable. Where is the place for gamma knife treatment of the brainstem gliomas and cavernous hemangioma? We'll see one of the cases was treated with surgical intervention, but for some lesions there is no place for surgery.
Actually, for cavernoma, we have treated 4 cases till now with cavernoma. One of them is in the brainstem, but what literature is saying about this is control of the growth of cavernoma and decrease the rate of bleeding after 1 year of giving gamma knife. But some cases will show shrinkage. The shrinkage is between 20 to 25% in cases of cavernoma. Low-grade glioma is still, it is a control of the growth for 50 to 60% without guarantee to treat it completely, because these neoplastic processes can escape from the radiation therapy.
One more question from Dr. Mazaqa.
Can this gamma knife convert a benign tumor into a malignant one?
The reported incidence of gamma knife regarding the benign condition, and the most common benign condition is the vestibular schwannoma and meningioma treated by gamma knife. The rate of transforming after giving gamma knife, we know that some cases, by its nature history, it will go by 1% for meningioma and vestibular schwannoma to malignant transformation. After gamma knife, they reported below 0.5% in cases of meningioma, but no case in vestibular schwannoma tend to be malignant.
Second question, what is the age limit?
We can do from 4 years up to 100.
Not below 4 years.
Yeah, 4 years. Yeah.
Okay, thank you, Dr. Abdulrahman. Welcome. The next speaker will be Dr. Tahir Jambek, a consultant in neurosurgery with spine subspecialty. He is running his own private clinic. Dr. Tahir is a member of the Society of British Neurological Surgeons, European Association and American Association. Welcome, Dr. Tahir.
شكرا للأستاذ الدكتور محمد البربراوي واللجنة المنظمة على الاستضافة. Thank you to have me here today. Today we will talk about Today we will talk about the minimal invasive spine surgery and something we call it the queen of the minimal invasive spine surgery. It's the endoscopic spine surgery. Our cases is distributed between my private clinic and the Prince Hamza Hospital. We'll talk about our series is 300 cases, and that was in the last year. We didn't update this year. So I'm sure that everybody knows about the anatomy and oriented about the anatomy. Spine surgeon long time ago thinking about having the access for the spinal canal through the, let's say, natural orifice or natural foramen. And we do have the foramen on the lateral side. We know the anatomy that we can identify two routes, one exiting route, and this is on danger when you are thinking about to enter this foramen, and the transmitting route, which is in the canal. So it's you have the borders of the superior pedicle, and inferiorly you have the SAP, that's the superior articular process, which make the borders of the foramen. So minimal invasive surgery is not allowed just a small incision. You have 6 millimeter incision, 1 centimeter incision, 2 centimeter. This is one element or one description, but the time of the surgery is tremendously important. If you want to go for minimal invasive, you have to be minimal on the patient, like minimal harm on the patient. We are always surgeons. We cut the skin, we cut the organs, we reach our target. So the time is important for the anesthesia. The approach itself, when you go through a difficult approach, when you go through an easy approach, this is very important. What is the harm you cause through your surgery? So everybody wants minimal invasive. This is the patient, surgeons, industry, so we can't ignore it. So the endoscope. The strength of the endoscope is less approach-related trauma, preservation of epidural blood supply, and reduce epidural scarring, which is really challenging for the spine surgeon. The scarring. You do a beautiful surgery, after 6 months or 1 year, the patient comes maybe with the same symptoms or something like this. You do an MRI and you have the scar. So reduce the infection rate and hospital stay. The drawback of the endoscope is it has really steep learning curve because you will change the concept. You will look for the screen. You didn't look for the tissue itself, and you have the 2Ds. You don't have 3Ds like we used to do our surgeries. So the long and the steep learning curve is a problem. Longer operative time, and I'm focusing on the operation time. It should be really less. Doesn't matter in the first cases. We are always learning, but you have to reduce the time. Important dural tear, you can't cope with the endoscope. You have to convert to open. Radicular pain and paresthesia through the irrigation system or radio frequency or the cannula itself, as we talk about the exiting nerve root. This is important. So percutaneous endoscopic transforaminal scectomy, used for mostly for the lumbar, which is the most common herniation, which comes lateral or paracentral, let's say. Requires special training and special instrument. And it has its challenging indication and contraindication. So the indication of the surgery is the same indication we all know about, the open technique or an MIS technique, nothing unique. The radicular pain, the positive nerve tension, the failure of medical treatment and codeine and others. By experience, by time you push your limits, you get out of the comfort zone. And surgical technique related and the challenging, this is the recurrence disc, the migrating disc, the sequential of the sequestrated disc, and central. If it becomes central, this is difficult. And previous surgery and adhesion make your mission is very tough. But there is some elements which is patient related. When we go to the lateral foramen, if you have a high riding iliac crest for the L5S1, this is something very challenging, and sometimes it's impossible to go there. You have scoliosis, this is a challenge. You have spondylolisthesis and calcification and severe degenerative. This is really challenge. Obese patient, challenge. And high up L1, L2, like herniated disc. So you need to be careful because you have a visceral injury rate, which is really minimal, but keep it in mind. So we talk about the advantage, which is safe, effective technology, direct visualization of the pathology through the camera, less blood supply and less trauma, fast rehabilitation. Disadvantages, this is a narrow window of the patient. You couldn't go transforaminal with all your patients, and you couldn't have just those foraminal and extraforaminal patients. So you, as we said, you push your limits. And the learning here. So I'll talk about the technique a little bit. We have something called TSIS, which is standing for Transforaminal Endoscopic Spine System. The position, you have the option to go for lateral position or for a prone position. Lateral position carries an advantage of having the belly is relaxed, you don't have a venous engorgement, and you don't have a buffy face, and the patient would be really easy. And the system, you will have carrying the system all the procedure long. So when you have a lateral position, you just put a gentle support for the system, which goes with the gravity, and it makes really big difference, and rather than to carry the system in a 45 degrees. And the position of the surgeon, believe me, as a neurosurgeon knows, this is a long procedure. A neurosurgeon go with the long procedure. So you have to have a relaxed shoulder, relaxed hands. Your posture is very important to give the patient your time, to give the patient the maximum you can. You have to be in a good position. So the surgeon position is very important. We start with a needle. We go to the SAP, superior articular process. Some technical measurements. You go between 10 and 14 centimeters away from the midline, according to the level, according to how patient to be or fan. And you go to the foramen, to the Campbell triangle. You have the superior articular process. We always say that the bone is home. So you go to the bone rather than to go to any soft tissue. When you reach the bone, you know yourself that you are in a good position. So you start something, we call it reaming, to do a foraminoplasty. Okay, now I show it to you. Oh, I'm going to big there. There was some videos there. It's not working. I know how can I we go for reaming, we do a foraminoplasty to anchor the cannula, which is 6 millimeter, and you will have, this is your cannula, you will have all the instrument inside. When you anchor the cannula in the foramen, and you put the, here is the area which we are landing on, and we will have a reaming. So this is the appearance on the cannula. Then you go inside and have some cutting, some more exposure. You will see the nerve and the disc. Mostly it will be sequestered disc and take it out. Complication. Surgery means some kind of complication. It's really low, but there is a rate of nerve root damage, post-operative dysesthesia, dural tear, post-operative hematoma, wound infection, I've never seen, visceral injury, I've never seen. So the key is in the landing of the needle, the herniatomy, and the point of ending. I will be quick. So the landing, we talk about the landing. The difference where you will follow the sequester. If the sequester is the laterally, you go vertical, or steep is the sequester is to the canal, you go horizontal. So the landing is important. We'll focus another time on the injury of the exiting groove. It shouldn't be injured. You go down, caudal as much as you can to the SPV, go to the home, to the bone, and will never injure. And you will have the sequester, you release, and you take it off. Sorry, I have some videos, but it's not working. When you end the procedure, when you will see the pulsation, this should be, You will end the procedure when you see this. The nerve and the dura is getting pulsating nicely. You are in a very narrow place, so if you didn't release, you will never see this. Here we have some challenging cases, post-fixation and open surgery scarring. Then the patient comes with a lateral sequester and overriding iliac crest. Our series has 300 cases, 60 minutes as a operation time, 6 millimeter the incision, and I'll go through just the positive things. We have 3 dural tears. One of them is symptomatic. And this is one of the dural tears. You can see the rootlets coming out. This is 2 millimeters dural tear, so don't worry about it. Okay, thank you very much.
Thank you very much. Very interesting. We have one question. ايش اللي حاطين مفتين عليه الطلاب؟ One more question. Sorry, one question. Any question? Okay.
Dr. Tahir, how many times did you compare those procedures in one?
I write it down, but because I'm really quick. 2 times. Not because the dural tear. I'm not really worried about the dural tear. We don't always. But because I was not satisfied about the tongue, I thought there is some inside. I was right.
Is it easy to open the lateral recess using a swab?
Good, Dr. Tahir. Thank you very much, Dr. Tahir. Good experience, and we appreciate that.
Okay, our next speaker is Dr. Faizabeh. Dr. Faizabeh is a consultant was ex-consultant in the Hussein Medical Center and American Fellowship in skull-based surgery, consultant in skull-based and micro, interested in microsurgery and spine surgery, and is a member of American Association of Neurosurgery, as well as American Fellow of Skull-based Society.
Assalamu alaikum wa rahmatullah. Thank you very much for kind invitation. Shukran Dr. Muhammad for organizing committee. Actually, my lecture is, I'd like to share you, it's not a usual lecture, it is actually an extraordinary talk. I consider that. First of all, it is I consider it's extraordinary injuries in the nature of the injury, in the anatomy, the site of the injury, and some of them carries a lesson, teaching lesson, especially for the juniors. So, since the since the Eisenberg, since the Eisenberg in 1990, the severe head injury is defined with any Glasgow Coma scale less than 8 within 48 hours of impact. So this definition, I think it is still valid till now. And the guidelines for treatment of severe brain injuries, there is a lot of abstracts, a lot of protocols, but it's not in the focus of our talk. But the penetrating head injuries, you know, depends on the severity of the injury, and either high velocity or low velocity, multiple fragment inside the brain or inside the spinal cord with the spinning effect of the bullet and shockwave effect. First of all, I choose about 7 cases to show you. Most of them carries a lesson from the nature of the injury. This is one case of, I know every one of you is confirmed to see the epidural. This is an epidural hematoma, very huge epidural hematoma. Why I want to show you this? Because this is significant of ongoing bleeding. This is of epidural hematoma, of ongoing bleeding. This is a very important lesson in this case for the juniors, because the patient can die from this disease. Anyone can argue that. Can he die? Yes, he can die. The time factor is important, so he can be saved with early intervention. If you delay, the patient either die or he will have a severe morbidity. So it's very important. It's unusual to find this very severe case like that. You see, this is the patient. Look how big is this hematoma. The patient, it can be saved immediately after surgery. This is a very important lesson. We have to know, we have to deal with these cases immediately. This one case, which I consider it a mobile bullet syndrome. Bullet which can enter the brain, and the patient, it's very rare incident, the patient, when he changes his head, he will have hemiparesis in the contralateral side. When he repositions to its origin, his symptoms subsided. This is what we call it a mobile bullet syndrome. Yeah, you have the bullet, how the position change. And when we remove the position of the bullet, the patient resolves his symptoms. This was one case with the bullet tunnel. You see, how is the tunnel from inside to outside? This is inlet. This is a hematoma tunnel from inside to outside. It's very strange to find this signs. One case he is a carpenter, a working carpenter. He is a complete penetration of a nail number 10 to the brain, nail size 10, with inside the motor area. Just it's in the left side as if he's targeting the motor area. Look at this body position. The position of the body inside the motor area, traversing down, complete inside nail. One surgeon suggested to remove the nail as if he extract a nail from a board like that. So look what's the hematoma. So you see there's a big hematoma in the motor area. Sorry. Yeah, so you see that the hematoma here? And the patient came with the hemiplegia, the outside with aphasia, and after intensive care of physiotherapy, he could walk with him, but we said to him, he's a young man, 21 years old. This one case. Another case, which I want to show you, this is a very strange injury. It's a bullet from temporal region inside the cavernous sinus. You see? Look at that. He's a policeman. Shot from this side. But what's strange in this injury? When we opened, we found that this is the buckles of the helmet. You know, the police لابس الهلمت الزر buckle, the buckles, the bullet shot the buckle العقد اللي بيمسك فيها الولد delivered inside the brain to the cavernous sinus. Very strange injury. Another injury. Yeah. See? Yeah. This is one doctor, Syrian doctor. He's a doctor. He's the father of 6. He lost 3 daughters and 3 sons with barrels inside. Shot him and died. And very strange. He got an injury. Very big shrapnel injury, about 2 centimeters inside the torcula, just directly inside the torcula. You know, the torcula is the confluence of the sagittal sinus with the transverse sinus. It is inside the torcula, completely inside the torcula. You see? Look, 2/3 of it inside the torcula, inside the brain, and 1/3 is outside. And he came with this lead. Look. Inside, completely inside the torcula, exactly. So the CT scan, and this is exactly how it's inside the torcula. So we operated him the next day in lateral position. We cannot anesthetize him in the prone position, put him lateral. So we prepare periosteal, pericranial flap, and we explore circumferential cavity around it, and we could remove it and repair, yes, you see, and we remove it, and later on, after 3 months, we did a cranoplasty for the defect for him. This is very interesting injury. It's a fence injury. An engineer, he is landing في شجرة تين، وقع landed a frame على سور البيت، فالميتال فنس، البورشن ميتال فنس زي الرمح هذا hit him in the temporal region and exit in the outside. You see, he arrived the hospital with this 1 meter fence with his head. الدفاع المدني طبعا they couldn't cut it لانه بيعمل هاي حراره عاليه، الحراره العاليه بتحرق البرين، فما بقدروا، فقصوا متر حديد متر بالشبك with his head. Arrived the hospital with this fence inside him. So we took him with this. You see that this is the injury. From here, you see how this is the auricle, the ear, and this is the fence injury from hitting this. Inside this is the blood. والمتر هذا كله اجى arrived to the hospital. We took him to the theater with this, everything with him to the theater. And you see, we remove it from here to here. And we found that it is just fracturing the temporal bone. It's not causing any major injury. Just you could see the middle meningeal artery inside.
Do you have the CT scan?
Yeah, And then we didn't see this kind of normal until 1 week. Yeah. This is one interesting injury. A boy who is 13 years old, in the midnight, he has stabbed knife.
Please, no side talk.
He has a stab in the back, just in the spinal cord, and he's arrived, he's calm, vital signs stable, moving his limb. The knife is a hard resistant for manual removal. You cannot remove it. So what's interesting, when you see this knife completely inside the spinal cord, but what's interesting in this? Look, look the CT scan. If you have a navigator, you cannot put it in the pedicle screw. As if you put a pedicle screw, taking the whole pedicle down to the body. So if you put it under navigation, maybe it's possible to put it like that. Look, you see the view? This is the 3D. This is a CT scan, the lateral picture, how the pedicle screws inside reaching the body. So, this axial cup, completely in the pedicle. So, and then we remove it in the operating room without any harming him. You see, this is the knife, and this is after recovery. He has no any sequel. So I brought these cases for you to teach for the junior mainly. There's a lesson that some injuries may be lethal anatomically or the question of the injury, and sometimes maybe the patient maybe القدر Allah subhanahu wa ta'ala save without any serious injury, and with transfer to a specialized hospital with available facilities and experience, most of the cases can be saved in this injury.
Thank you very much. حقيقة this reflects the real neurosurgical journal. We are proud of you, Dr. Faiz. ونقدر really قديش احنا نشوف حالات injuries, none of them was encountered in our practice. وبالتالي you've done a great job and you saved lots of patients. يعني we are proud of you, Dr. Faiz. Thank you very much. We leave the stage. أنا أحكي لأنه في تصويت vote for the best lecture. فأنا خايف أحكي نعمل vote تأخذ لا لسه بدنا نسأل دكتور فايز ليش مساعدة؟ We leave the stage for معنا دقيقتين for 3 questions. Any question? Any question? تفضل. You mean behavioral changes or psychological sequelae? Yep.
Some of them, yes, especially the Syrian patient. He lost 6 siblings, 3 daughters and 3 sons. It's fascinating that he after we did the cranioplasty, and after 3 years he returned back to Dar'a, and he has another injury and he died on spot after 3 years. When he returned back to Dar'a with another injury. It's been definitely psychologically very upset of losing 6 siblings.
One question. Another question for Dr. Muhammad. Have you done a CT brain for the guy with the fence in his head?
Yeah, we did CT scan after we removed this.
No, before.
We cannot. Possible.
But really these are very interesting cases. خاصة حالة الإبيديورال هيماتوما إنه when the patient had the CT scan, the hyperacute blood was black. عادة الهايبرacute blood بيبين white. بالبليدنج بيبين black. فكان المريض بتصور وكان ينزف وكان عنده brain herniation وبالتالي imminent death was around. Thank you again, Dr. Faiz. Our next speaker is Dr. Salim Lidweri, Vice Dean of Hashemite, the Faculty of Medicine in Hashemite University. But before that, he was our medical student, graduated from Jordan University of Science and Technology, ended his higher specialization in neurosurgery from King Abdulla University Hospital. He was our trainee, one of the best trainee, لأنه احنا عندنا تصفيات عالية بالإقامة وبالتالي البقاء دائما للأفضل. الإلكشن شو بسموها هي قانون الانتخاب الطبيعي الناتشرال إلكشن، فما بتضل عندنا إلا البست ريزيدنت ولا لا هو حميد. يعني we are proud of him. He finished fellowship in Australia, Sydney Macquarie University. Then upon his return, he started to practice neurosurgical spine surgery في برنسس حمزة وبالجامعة الهاشمية.
السلام عليكم ورحمة الله، بشرح لي صدري ويسر لي أمري. بداية كل الشكر والتقدير لأساتذتي ومعلميني الموجودين، الأستاذ الدكتور محمد البربراوي والأستاذ الدكتور محمد أبو جاموس. وأنا صراحة يعني فخور بوقوفي هنا، فشكرا على الدعوة الكريمة. هذا بداية. الشغلة الثانية اللي حاب أحكيها لأبناء الطلبة واللي راح يكون مستقبلا زملائنا زي ما تفضل الدكتور عبد الرحمن جديفات بداية حديثه. Whenever you have the opportunity, try to bring with you to your country knowledge or technique. I hope I brought something valid to my country to serve our patients. Today I'm going to talk about briefly about a very important topic that has been evolving the last 10 to 15 years, which is sagittal balance and spine pelvic parameters. If we have learned anything, or one of the most important things that we have learned in the last 15 years, is that posture is one of the strongest indicators for patient satisfaction after surgery. As we all know, our normal posture when we are standing is the head should be located over the shoulders, over the hips, and over the knees and the ankles. Okay. And as we all know that life is a kyphosing procedure. What I mean by that, as we get older, we tend to bend forward. Okay. And that unfortunately interferes with two most important things, which are the gaze, as we try to look horizontally, and the using of our upper limbs. Okay. So, as I mentioned before, posture is the strongest predictor of long-term patient satisfaction. And this is a fact. It's not a trend, it's not a personal observation, it's not an institutional observation. This is fact. Okay. So, as we all know, especially for the respectful spine surgeons, the goal of any surgery, while you are doing spinal surgery, either anterior approach, lateral approach, the three goals of our surgery is to decompress the neuronal elements or to eliminate the pain generator. The second thing is to, if you are going for fusion, obtain arthrodesis. And the third and very important thing is to maintain or to restore the curves. Okay? These are the three main goals. Unfortunately, sometimes we forget about the third goal. Okay? What are the options to restore the or maintain the curves? Either you go anterior, X-lif, A-lif, L-lif, anterior column reconstruction or whatever, by distracting the anterior column, or by compressing or contracting the posterior column, okay, by simple compression, facetectomy, PSO, Schwab's osteotomy, or whatever you want, okay? Okay, now, after knowing the importance of maintaining or restoring the curves, what's the next step? What am I going to do or to learn how to apply to my surgical plan? First of all, we have three main steps. First of all, measure the pelvic incidence, like actual pelvic incidence. Evaluate the harmony of the spinal curves, which is relationship between the pelvic incidence and the number of lordosis. And to identify if the patient is compensating with the sagittal imbalance or not. Okay. Now, anybody knows what is pelvic incidence من الطلاب؟ سامع بالpelvic incidence؟ Okay. Okay. So, sorry. So the pelvic incidence is the orientation of the sacrum inside the pelvis. Okay. So this is sacrum, and this is the pelvis. Okay. The more horizontal sacrum you have, like here, okay, the higher pelvic incidence angle you'd have. And this implies that to be okay, you need to have a larger number of doses. Again, so pelvic incidence is the orientation of the sacrum inside the pelvis, and it's constant. It's constant. Everybody is born with a constant pelvic incidence angle. It's not mobile, it's not dynamic, it's static, okay? This angle, this is the center of the femoral head, okay? من midline لحد midpoint of the sacrum. هذا الخط الأول. الخط الثاني اللي هو which is a line that is perpendicular to the sacrum. This angle is the pelvic incidence. Okay. What does it mean? The higher the pelvic incidence you have, the larger anterior posterior diameter of the hip you have, the pelvis. Okay? And we can group all the world into three major groups. People with low pelvic incidence, okay? Which means a small anterior posterior diameter of the pelvis, mid-range pelvic incidence, and large pelvic incidence. And here's the problem, in fact. People with a large pelvic incidence, because patients with large pelvic incidence, they need larger lumbar lordosis, okay, to maintain their sagittal balance. Okay, so this is the first step. Measure the pelvic incidence. And this can be done by simple lateral static X-ray of the patient. Two femoral heads and the sacrum. Okay, it doesn't need an EOS, doesn't need a whole spine X-ray. It's just a simple standing lateral lumbosacral X-ray. Now, first step. Second step, is there a harmony between the lumbar lordosis, the pelvic incidence? This is a very important issue to consider. Okay, because as I mentioned before, patients with, for example, patients with low PI, patients with mid-range PI, and patients with very high PI. Okay, so here the PI is almost 30. Your target is to maintain a lumbar lordosis intraoperatively around 30 plus minus 9 degrees. Okay, patients with mid-range around 50, and with the high PI is around 80. Okay, now talking about the harmony. As we all know, around 70 to 80% of lumbar lordosis is maintained between L4 to S1 signals. Okay? What does that mean? That means when a patient is having a PI, as we mentioned before, you need to have, or to restore lumbar lordosis for a higher degrees. Okay? And this will give you more option to do intraoperatively. What I mean by that? Patients with with a low PI, patients with a very high PI. If you do an X-ray for normal patients with a normal PI, normal lumbar lordosis, patients with low PI, the apex of the lumbar lordosis will be low. So L4, maybe L5, okay? Patients with high PI, you will notice that the apex of the lumbar lordosis is higher. So you have more options intraoperatively to do. You can go up to L2 or even higher, okay, to maintain more lordosis intraoperatively. And the final step is to check if the patient is compensating for his low lumbar lordosis in comparison to his pelvic incidence. And what are the compensatory mechanisms? There are few. The most common compensating mechanism is pelvic tilting. So the patients, when they are kyphosing, they need to look horizontally. So to compensate for their loss of lumbar lordosis, they tend to retrovert their pelvis, okay? So their mid-body will go anteriorly, so they can look more horizontally, okay? The second most common compensatory mechanism is flexion of the knees. وده بتلاحظوا بالشوارع بالمولات and etc. Patients that are kyphosing, if you look at them from the side, they tend to retrovert their pelvis and try to flex their knees and walk slowly, okay? So this is a compensatory mechanism. So, going back, hit the point. Three most important parameters for surgeons. Pelvic incidence, measure the pelvic incidence, look for the harmony between the pelvic incidence and the lumbar lordosis, and measure the pelvic tilt, okay? And the pelvic tilt is, we'll go there, okay. So, this is the read X-ray, sorry. So this is the lumbar lordosis, which is the angle between the superior and the plate of S1 and the sacrum, there. Something called the sagittal vertical axis of the C7 plump line, which is a vertical line going from the mid-body of C7 down to the ground, and we measure the distance between the posterior sacrum and the C7 plump line. The normal range is between 5 and 10 centimeters. The pelvic tilt is a angle between a perpendicular line to the floor to the mid-sacrum. This is the pelvic tilt, and this is lumbar lordosis. How can this be done? في عندنا أكثر من software. One of the most important and free, most common, useful اللي هو SurgiMap. It's a desktop-based tool. نقدر نقيس فيه PI, lumbar lordosis, PT, SVA, and etc. Okay. Just in case to عشان نطبق الحكي اللي بنحكيه ما يكون هيك solid و theoretical. So this is a 64-year-old male had multiple laminectomies with low back pain, bilateral L4-5S1 pains. This is his readings, okay? As we can see, his SVA, which is the sagittal vertical axis, is around. Next. Okay, so it's 16. The normal range is between 5 to 10. 5 is ideal. Up to 10 is acceptable because as we grow old, we tolerate higher SVA. His PT is 54, the ideal is below 25, and the most important is PI-LL ratio, which is 41 to 1. Lumbar lordosis should be normally 41 plus minus 9, okay? So this patient needs lots of lordosis. Otherwise, he will come after 1 or 2 years with failed back syndrome, adjacent segment disease, and etc. And it has been proven that a mismatch between PI and LL of more than 11 degrees carries a 75% to have a failed back surgery and adjacent segment disease. So this is after correction, intraoperative. The PI is constant, as we said. SBA was 16, less than 10. The lumbar lordosis can almost 0, 35. And thank you very much.
Thank you very much. والفيزيكس يعني very very difficult subject بس well done يعني تكنولوجيا يعني اشياء ادفانس بالسباين سيرجري يعني اكيد الدكتور طارق يعني انترستد فيها او اي سباين سيرجن. any question? Yes.
I have a question that I'm interested in. Do you think the pelvic incidence affects whether the patient in the future will have a disc or not?
No, no, it's just a normal variant. زي ما انت لك طول معين عرض معين you have a specific PR. Okay.
يعني القصد انه للمانجمنت والتريتمنت وليس للبريدكشن او سكانينج. Any more question? Yes.
Sorry?
Presentation for abnormalities.
So, severe agony in the back. لأنه البيشنت لما يكون compensating, he needs to flex his knees, he needs to extend his back and retrograde his pelvis. So all of these will keep the paraspinal muscles in continuous contraction. تخيل انت ماسك كاسر ومادي ايدك زي هيك continuous contraction. في طرز بتحكي انه هذول المرضى بيجوا بسيفير back pain. The pain reaches up to cancer patients' pain. Okay.
Okay, thank you very much, Dr. Samuel.
Thank you.
Thank you, Dr. Salim. Now our next presenter is Dr. Al-Barbarawi. دكتور محمد البربراوي طبعا غني عن التعريف ورئيس المؤتمر الحالي والمبادر لهذه الفكرة التي تحدث لأول مرة في المملكة. الدكتور محمد هو رئيس جمعية جراحة الأعصاب في الأردن حاليا. He's a professor of Neurosurgery with fellowship in skull base and vascular surgery. And he's
يعطيكم العافية و welcome to this very interesting event, the unique one. I'm going to talk about a rare subject. It's not common in the neurosurgery practice, but I think we have a large number, one of the largest numbers across the world, which is management and the treatment of giant and large aneurysms. طبعا تعرف aneurysms very common disease, but they are small, ranging between 5 and 10 millimeters. But at King Abdulla University, when we started to establish the vascular subspecialty practice or service in here, we started to treat patients with large and giant aneurysms. So this is a little bit difficult subject. It's not common across the world. The largest series I've ever read was 104 cases in 20 years by Michael Morgan from Australia. Those are my escorts who did this work with me. So this is a large aneurysm, as you see in there. بلشنا بالأفلام. هاي. You see, this is a large aneurysm, PICOM, large aneurysm with multi-layer, and this is the real aneurysm in there. So this is a multi-layer, the thrombosed aneurysm, 3D that shows the aneurysm. Again, ring calcified large aneurysm, the real size in there, which is the ICA bifurcation, and this is after coiling. So large intracranial aneurysms, as you know, defined, when the aneurysm is more than millimeters, يعني من 1 سم إلى 2.5 سم, it's called large aneurysm. When it's more than 2.5 millimeter, we call it as giant aneurysm. The treatment of these lesions associated with high mortality and morbidity rate, and they can present either with mass effect intracranial hemorrhage, stroke, or seizures. Next. We operated in here in 45 cases from 2004 till 2021. 33 cases were giant aneurysms, 21 were large aneurysms. The average age 4th or 5th decade, and most of them are located in the anterior circulation. Less than 10 cases located in the posterior circulation. Next. Mass effect was the initial presenting symptoms. Some of them presented with ischemia or ICH or intracranial hemorrhage is not as common as in small aneurysms. Small aneurysms, they present with subarachnoid hemorrhage, more commonly in more than 90%. In giant aneurysms, they may present with mass effect or rarely hemorrhage or seizures. Next. As you see in here, this is a large MCA aneurysm in a young female patient who presented with sudden onset of bad and severe headache, the worst ever experience in her life. And we saw that there is a bleeding inside the aneurysm itself. It didn't cause subarachnoid hemorrhage as in usual cases or representation. Next. This is a ring calcified aneurysm. Next. Thrombosed MCA versus PCOM aneurysm. Next. Multi-layered aneurysm with intraluminal bleed. You see the hyperintensity. This patient presented with this bleeding. And this is the real size of the aneurysm, but the actual size is that huge one. Next. And this is post-coiling. This is intraluminal bleeding, CT and MRI, and in there. Next. So technique used for treatment of this is variable. Most of them underwent endovascular embolization. 32 cases treated with surgery and 22 with endovascular embolization. Most of the 32 cases underwent direct clipping or resection of the aneurysm. We resected the aneurysm, then we did aneurysmography, repairing of the arteries. And the rest of cases had endovascular embolization. Two of these cases were a vein of Galen aneurysm. طبعا تعرفوا Galen, one of the يعني هذول Roman anatomist who discovered the vein of Galen, or described the vein of Galen, and described 8 or 7 cranial nerves. The first one to describe the cranial nerves was Galen. Next. And this is my team. We did an aneurysm for the supracranial aneurysm in there. And this is the clipped aneurysm, bifurcation and aneurysm in there. Next. My great team who helped me. Next. This is the vein of Galen aneurysm. You see, it is the formation of internal cerebral vein with the straight sinus. This is the straight sinus. This is the AP aneurysm, and we see the aneurysm during the phase of the arterial phase of the angiogram. And this is the lateral cut in there. This is the vein of Galen, and this is the straight sinus, and this is a very interesting MRA and MRV that shows the large vein of Galen aneurysm with the straight sinus in there. Next. This is post-coiling of that case. So this patient underwent coiling. And this is the artifact of the coiling. Next. And the patient had heart failure, as you see, cardiomegaly. So patients are children who presented with vein of Galen may present with heart failure due to high blood flow of the aneurysm that resulted in high output heart failure. Next. Results, excellent results achieved in 38 cases, that is to the international figures. The international figures are reaching between 70 to 80%. Our excellent results approaching the international figures. 70% had excellent results, and 10 patients يعني كانوا with moderate to severe disability, and mortality rate in 6 cases 11 يعني identical to the international figures. We are proud of this. Next. Conclusion. Recent advances. طبعا المورتاليتي ريت بالجلدات keep going. طبعا نرجع للهيستوري اوف انيرزم، يعني حتشعروا انه كان يعني التاريخ تبع الهيستوري اوف انيرزم شويه فني. اول واحد ديسكرايب الدايليتيشن اوف انترنال كارتيد ارتري كان مورجاني. تعرفوا مورجاني هم ديسكرايب للبيدياتريك انوماليز، وعندنا الديسكربشن تبعت الترانس شو اسمه دايفراغماتيك هيرنيا. فهو اول واحد وصف لنا الدايليتيشن اوف ذا ارجع قدم يعني الانيرزم. بعدين لا شوي طول بالك يا زلمه، هدي شوي. بعدين بلشوا يوصفوا انه في ruptured aneurysm described in Italy by millennium. بعدين اجى جون هانتر described the popliteal artery aneurysm و he did some surgeries for it حتى يقلل الفلو، وبالتالي as a part of the treatment للانيرزم. فجون هانتر كان جنرال فاسكولار سيرجن. السبارابلويد اقرا بلش اول ديسكريبشن لها سنه 1814، اول ديسكريبشن اوف سبارابلويد هيموريج. بال 1890 فيكتور هورسلي طبعا ديسكرايب او اوبريتد على بيشنت كان عنده لارج او جاينت انيرزم. هي ثوت ات واز سيست، فهاي السيست كان سماها برين سيست وعملت له ماسيف بليدنج. للاسف بعد ما خلص من العمليه هي باست اوي، لانه ما كان يعرف انه ات واز ا جاينت انيرزم، فكان يشتغل على انيرزم without proper preparation that ended with massive bleed and the patient died straight away. Next. بعدها اجانا هارفي كوشن the father of neurosurgery اللي بلش يشتغل على الانيرزم. عمل عمليه بيتيوتري ادينوما، فاكتشف انه هاي البيتيوتري كانت bleeding like hell، فما فهم ليش كان اعتقد انها كانت بيتيوتري ابوبلكسي، فما عرف ليش قاعده بتنزف he couldn't control the bleed، فالبيشنت again died. وكرر نفس العمليه وعمل another patient with giant aneurysm، عمل له اياها as brain cyst، لانه كانت الجاينت aneurysm at that time تعرفوا ما كان في سي تي سكان، كانوا يشتغلوا على النيومو سيفالو فنتريكولوس سيل، وانهم يعملوا على الانجيوجرام فيشوفوا الابنورماليتيز على الانجيوجرام او على السكال فيعتمدوا عليها، فيفتحوا راس المريض بناء على ذلك قبل السي تي سكان ايرا. مثل ما حكى الدكتور وليد معنا من يومين انه الفيزيست البريتش فيزيست هانس فيت هو انفنتد ذا سي تي سكان in 1970s. وبعدها اجى العمل اول انيرزم بعد ما اكتشفوا الانيرزم كليبس داندي ووكر ذا فيلو اوف هارفي كوشين، يعني كان هو الفيلو زي سالم وزي وليد وزي هذول كانوا الفيلوز، بس للاسف يعني داندي he didn't appreciate his consultant، وبالتالي صاروا على خلاف in the future، وطلق مرته هارفي كوشين لأنه ما كان يروح على البيت، ما كان يشوف مرته ولا عائلته. فبعد ما طلقت مرته منه داندي تزوجها كنوع من الانتقام من هارفي كوشين. This is the history of neurosurgery طبعا. أول تعملوها شباب يعني مش رسالة. طبعا جاء بعدها محمد غازي زرقيل، هذا برضه اشتغل في الحرب العالمية الأولى وكان تركي وهرب من تركيا إلى شو تسميها بريطانيا زيورخ أول شيء، طبعا لأنه كان ضد الحرب وكان شيء، وقعد هناك 5 سنوات مرمي في الاناتومي لاب وما حدا كان ساعد فيه ولا حدا عبره، وبلش يشتغل على البرين اناتومي وعلى البرين ارتريز، وبعدين هاجر الى امريكا وهنالك تم اكتشافه، بلش يشتغل شوي شوي ويدلل للنيوروسيرجنز حتى يعني اقتنعوا فيه وبلشوا يشغلوه. Then he became the best or the neurosurgery of the century, the best neurosurgeon across the world, number 1. I think he's still alive. وإجا زار الأردن many times، يعني إجا زار الأردن مرتين أو 3 مرات وقدم العديد من المحاضرات، وهو من ابتكر المايكروفاسكولار نيوروسيرجري والمايكروسكوبيك نيوروسيرجري وأشياء كثيرة. طبعا بعدين اجت رينا فافالارو من ايطاليا وعملت الجريت فين اوف جالي، عفوا الجريت سافنس فين انستيموسيس للهارت، فاجى له في سرد هاي الفكره وعملها للاكسترنال كاروتيد ارتري مع الانترنال كاروتيد ارتري انستيموسيس. قبل هي زرقية ابتكر فكره الستمكه، الستينا شو بسموه الاستمكان، يعني بدأ سيربرال ارتري مع السوبرفيشال تمبرال ارتري انستيموسيس فور مويا اللي هو بيصير فيه بروجريسيف لوس اوف ذا برين ارتريز. نكست. فاحيانا ممكن انه احنا نعمل الاندايركت ابروتشز، اخذنا فكره الانتيريال لايجيشن انه نسكر يكون عندنا لارج جاينت انيوريزم في البرين، فممكن ندخل على الكومن كاروتيد ارتري ونعمل له لايجيشن حتى نقلل البلد فلو وبالتالي تقلل الانيوريزم. نكست. نكست بلاش هي. اوكي. عادة البرزنتيشن زي ما حكيناها ما في داعي نعيدها. نكست. اوكي. نكست. الان الباثوجينيسيس ممكن تكون ويكنس في الوول، بعدين بصير لنا انيوريزم فورميشن، بعدين انيوريزم جروث، بعدين internal bleeding, recurrent bleeding, thrombosis, multi-layered. Next. الريسك فاكتور الاناتومي اوف blood vessels، يعني هاي very important عشان aneurysm is very serious. Vesicular aneurysm is unique for a brain، يعني it doesn't occur extracranially. والسبب في ذلك الاناتومي of brain arteries they are swimming in the fluid, lack of bone support like other external arteries, ولاك اوف external elastic membrane ولاك اوف adventitia وهاي blood flow 20% of the blood or heart cardiac output goes to the brain alone، وبالتالي they are exposed to enormous burden of blood flow. والturbulence effect والhammer effect as we'll see next. وبتشوف هاي المالتي لامينيتد كيف الوول سيرفيس بيصير في عندنا مع الفايبريشن مع الوقت بيصير في دايليتيشن وبكون في عندنا congenital anomalies or weakness in the artery that resulted in this dilatation of the artery, the initiation of the aneurysm, then the growth of the aneurysm, then the rupture. Next. How does the aneurysm, زي ما قلنا لكم انه ببلش small aneurysm, they may evolve to large aneurysms وتعمل لنا recurrent internal bleeding due to hemodynamic hammer effect or turbulence effect that resulted in the vibration or frequent vibration of the arteries. لما يصير عندنا bleeding بيصير في عندنا fibrin deposition with calcium deposition. Next. هاي الهيستوباثولوجي فيزيفورم انيوريزم، فبتشوفوا قديش كلها فايبرين و calcification. Next. Risk factors، يعني زي ما حكينا هم الكوفي كونسبشن اللي بيشربوا قهوه كثير ممكن يصيبوا، فديروا بالكم مع الدخان. Next. ممكن انه يكون الانيوريزمز associated with fibromuscular disease مويا AVM polycystic kidneys neurofibromatosis vasculitis Ehlers-Danlos syndrome. Those are يعني accompanied anomalies. Next. Management direct clipping. Best treatment of choice direct clipping for short and long term. Endovascular embolization might affect the short term not the long term. لأن ممكن البلد فلو إنه يرجع يعمل لنا regrowth recurrence of the aneurysm، وبالتالي ما نمشي وراء الموضة والسمعة. كل الاستاديز تقول إنه direct clipping isolation of the aneurysm from the parent artery is the treatment of choice regardless of the other techniques. طبعا next. This is the aneurysm clip. Isolation of the aneurysm from the parent artery. Next. هاي من الحالات اللي اشتغلناها. Clipping of the aneurysm. Clipping of the aneurysm. بعدين بنفتح الانيوريزم بنفضيها من البلاد والكلوت والاشياء هاي. Next. الالترناتيفز حكينا لكم اللي هي الباي باس سيرجري استنكا او تبعت لوفيد هاي انها تاخذ الجريتر فين او سفنس فين ونعمل internal accelerated anesthesia بس يعني انا ما عملتها حقيقه بس I've seen many cases when I was in Australia. Next. هاي من الحالات اللي ترابينج تقدر تسكر البيرنت ارتري من الانيزم فوق ومن تحت بس. نكست. هاي الانيوريزم رافع عملنا many cases نشيل نعمل ريسكشن للوول اوف ذا انيوريزم بعدين بنرجع بنخيطه. نكست. Endovascular one of the options but not always applicable. Next. Long and short term efficacy. Next. Net result يعني حكيناها. Next. هاي تالا أيوة عفوا هاي لا she was in Australia يعني كانت playing with these wolf dogs. Okay. Thanks for the attention. Next. We need to rest sometimes. Did see ولا شو اسمها هاي وجرب. Next. And have a nice break. We're gonna show you a video of aneurysm clipping. السريع. إن شاء الله ما نطول عليكم. طبعا هاي من الحالات أعملها. أوكي. طبعا وين هاي زين مش مبينة. سكر الفيديو الأول. بجيب إياه. تقدر تسرعه. يعني هذا تشوفوا فتحنا الجورة وهذا الجليسترينج لاير اللي هو الأركنويد وهذا السيلفيان فيشر. تقدر تسرعه. وهنا نعمل ريتراكشن للتمبورال لوب بعدين نفتح السيلفيان فيشر والنايف 11. يعني أنا I love opening the Sylvian fissure with knife 11 يعني it's very simple very easy. وبتشوفوا هنا ال internal carotid artery هذا ال internal carotid artery deal with it. طبعا نعمل dissection around it نتأكد إن ال internal carotid artery وهنا عملنا ال aneurysm clip application هذا ال aneurysm. خلصنا يعني عادة في ماني مانوفرز بس هذا الشورت كات يعطيكم العافية. شكرا.
Thank you, Dr. Muhammad. We open the stage for questions. Any questions?
Yes.
Go ahead.
علي صوتك. هلا في عندنا احنا criteria for endovascular embolization and criteria for direct clipping. Coilable cases are going for coiling, clippable for coiling. We have to study the 3D of the aneurysm, its relation to the parent arteries, the dome size, the neck size, and the presentation of patient. يعني في criteria to go for coiling و criteria to go for clipping. شغله most likely related to the dome neck ratio وال direction of the aneurysm والlocation. Aneurysm clip yes. The application at the aneurysm clip لأن source of bleeding is the dome of the aneurysm ولكن separation على neck of the aneurysm اللي هو aneurysm clip application. Any question?
Yeah, I have a question. Is there an estimate of how many? Is there an estimate of how many cases in Jordan done surgically, not endovascular?
Surgery mean coiling ولا surgical clipping؟
Surgical clipping.
أنا أتوقع صرنا عاملين فوق ال 100 حالة في الملك المؤسس على الأقل ما بعرف أحمد شمول وين أحمد شمول؟ لأنه طلع الاستاديا كم من حالة انيوريزم دخلت عندنا الأردن. يعني قديش العدد أحمد سيدنا معجين؟ وأعتقد فوق ال 100 حالة كليبينج without يعني كويلينج. يعني حوالي 140 حالة انيوريزم كليب. أنا هاي الارتيكل بدي انشرها إن شاء الله تبعت الجاينت انيوريزمز، وبعدها هننشر الدايركت كليبينج. يعني عندنا 140 حالة دايركت كليبينج اوف انيوريزم which is the largest series in Jordan and I think in the Middle East. لأن الفاسكولار نيوروسيرجري is vanishing, is dying، ولا ما في حدا انترستد بهذا السب سبيشاليتي anymore even myself. يعني أنا not interested فيها anymore. Yes. هذا السؤال يعني قد يكون يعني عميق جدا، لانه مش يعني اذا قصدك انه والله احنا بنسكر البيرنت ارتري ولا من الفيزوسبازم. فهلا من الدايركت كليبنج المورتاليتي ريت كانت عندنا زيرو. الدايركت كليبنج يعني من السيرجري. من الناتشرال كورس اوف رابتشر انيوريزم ريزلتس عندنا مثل الانترناشونال فيجرز. الان من الدايركت كليبنج يعني I remember 2 cases ended with post-operative ischemia. 2 cases كانوا very straightforward, very simple MCA aneurysms وانتهوا بستروك unfortunately. الان من الفيزوسبازم الاوتكم بيكون ماتش مثل حتى لو صار عندنا الاسكيميا مع في عندنا بروتوكول ويل استابليشد بروتوكول ات كينغدال يونيفرسيتي هوسبيتال فور تريتمنت اوف بيشنتس وذ سباراتوري هيموريج. وبالتالي عندنا البروتوكول وي ار فيري اجريسيف وذ ذس. نعطيهم مغنيسيوم سلفيت، نيموتوب، نيموديبين، 3 اتش بروتوكول، وندخل حتى بالكومبليكيتد اسكيميا انه نحطهم على فنتيليتر وممكن نعطيهم باربيتيوريت انديوست كوما. We use this for patients who suffered severe vasospasm, symptomatic vasospasm ويعني they deteriorated وبالتالي حطيناهم على barbiturates.
I think Dr. Abdulla Shtefat from Jordan University has a comment.
First, we should encourage our students.
Yes.
تقدر ترفع السنين.
هي المايك مش اللي بيفروا البطاريات.
يوم كامل.
We should encourage our students for this specialty. I agree. I totally agree in this subspecialty is vanishing in the country. So we encourage our students, this large number of students and residents, to go for this specialty. We still need a neurovascular neurosurgeon. Especially like the Scandinavian country, now 80% of procedure will go for between 70 to 80% to endovascular intervention. And just 20 cases are pure surgery, 20%. So we still need a neurovascular neurosurgeon. This is very important. We in Jordan University Hospital, we have Dr. Tamimi who is doing the clinic, and as almost reaching 100 over 30 years. It is rare, but we need it at some time to salvage some patients because we have a problem in this. Some cases are not amenable for endovascular, and neurosurgeon should be standby to operate in these cases. Actually, the overwhelming of endovascular over the surgery is a good indicator that the science and technology are advancing. So we need a minimal investment for our patient. But at least 20 to 25 cases, we need a neurosurgeon in emergent cases. So please, our residents, our students, go for this specialty. It's a very difficult, it's very demanding, and I wish many students or many residents go for it.
Thank you for this, Dr. Abdulla. يعني أنا بحكي ال 140 حالة اشتغلتهم. أنا والدكتور أبو جاموس برضه انترستد بالفاسكولار نيوروسيرجري. He did lots of cases. بس يعني هي سبب الجاموس يعني لما انت يصير عندك انترا رابتشر انيوريزم، انترا اوبراتيف رابتشر انيوريزم، يعني أنت ترى عزرائيل in front of this under the microscope، وبالتالي الهارت ريت يوصل 210، البلاد بريشر 190، الاورمس فينتينج. لا احنا بنحكي للمريض للجراح. وبالتالي يعني انا بالعكس انا اتمنى انه يجي vascular neurosurgeons to take over، و this is very demanding و it's vanishing across the world لانه very difficult، وكل العالم يعني مهتم منه. why not to go for simple discectomy ولا simple carpal tunnel وتعيش ولا بكره يطلع لك واحد زي داندي يعمل مع معلمه شو اسمه مش حلوه. فخلينا الكاربال تانل صديقي.
I have a comment. Dr. Abdulla has done a very interesting study regarding the pathophysiology using the electron microscope in Just University, and I guess this is the only study in probably in the Middle East using electron microscope. You can meet Dr. Abdulla Muhammad later on. Anybody of the student who is interested.
عمل استدي على الفئران الدكتور جاموس على الانيشيشن اوف انيوريزم، ويعني ما بدي اتحدث عنه، بس يعني كانت ريلي فيري انترستنج ستدي واستخدموا فيها كل الفئران كيف بلشت الانيوريزم وبعدين كيف بلشت تكبر وكيف انتهت بانيوريزم فورميشن. يعني هي بتبلش انيشيشن جروث وبعدين بصير رابتشر او وات ايفر. فكانت فيري انترستنج ستدي حتى على مستوى العالم وليس على مستوى الاردن او الميدل ايست، وقدمها في احد المؤتمرات الدكتور جاموس. شكرا.
Our next speaker is a medical student in our university in 5th year. You are most.
Today I'm going to be presenting Isolated Tactile Cavernoma, a comprehensive literature review with a case presentation. This article was published in 2021 in the Journal of Helian Q1 with an impact factor of 3.5. Okay, this journal was published in 2021, Journal of Helian with an impact factor of 3.5, index Scopus PubMed. So cavernomas are benign vascular malformations which are part of they're benign vascular malformations which have a raspberry appearance. They are one of 5 major categories of benign vascular malformations, which include telangiectasias, cavernomas, varices, and venous angiomas. Their incidence is 0.5% of the general population, and they usually occur in the supratentorial region. There are only 25 known reported cases of tactile cavernoma. What is the tectum? The tectum is a part of the brain stem. It is the roof of the midbrain. It's the roof of the midbrain. It's the roof of the midbrain, and it contains. It's in the roof of the midbrain, and it contains 2 important structures, the superior colliculi and the inferior colliculi, which are responsible for the visual and auditory pathways, respectively. Here we report a unique case of solitary tactile cavernoma with tactile bleeding. Tactile bleeding is life-threatening and it is fatal. And the bleeding extended into the ventricles, causing recurrent intraventricular hemorrhages with a reversible perinode syndrome after successful resection. Our patient was 18 years old with no history of epilepsy, no surgical history, and no medical history. He presented to the ER with severe headache and inability to produce comprehensible sounds. He had no signs of meningismus, no trauma, no infection, and no medication. He presented prior to his presentation, he presented with a tonic posture, but he had no clonic movements, no opportunity eyes, and no tongue biting. Upon Upon reaching the hospital, the patient vomited 3 times, and upon examination, his Glasgow Coma scale was 9/15, which indicated an intubation. He had normal vitals, and his muscle power was 5/5, and he had normal muscle tone and reflexes. On an urgent CT scan was done, and there was a lesion suggestive of a diffuse hemorrhagic and vascular lesion in the tactile plate of the midbrain. This indicated an urgent EVD. On MRI, which was done on the next day, there was superacute blood involving the midbrain. Here we have the MRI sequences, T2, FLAIR, and T1. This is the lesion where he's pointing, and it was a heterogeneous lesion with a hemorrhage. Here's the lesion again. Next. On day 3, the patient started improving, and his Glasgow Coma scale improved to 15/15. He had no motor deficits. However, he had bilateral abducens nerve palsy with perinode syndrome. Next. So the patient was unable to abduct both of his eyes. On day 9, the EVD was clear, and the CT scan was clear from the IVH, which is the interventricular hemorrhage. So the EVD was removed. However, upon removal, the patient started deteriorating, and his Glasgow Coma scale decreased to 12/15. And we did an urgent CT scan, which showed grade 2 interventricular hemorrhage. So another EVD was inserted. On MRI, there was a well-defined heterogeneous signal intensity lesion, measuring about 1.8 by 1.7 by 2.1 centimeters, seen diffusely in the midbrain septum, causing moderate obstructive hydrocephalus and interventricular hemorrhage. A digital subtraction angiogram was also done, and it was negative in 2 occasions, suggesting tactile cavernoma. After stabilization, a surgery was done. The technique was suboccipital craniectomy with image-guided supracerebellar infratentorial approach for gross microscopic resection of the tactile cavernoma. In the operation, a tuft of abnormal tiny vessels surrounded by yellowish tissue was found. Upon histopathology, areas of hemorrhage, fibrin deposition, gliosis, hemosiderin-laden macrophages, and clusters of vessels were found, and that confirms the diagnosis of tactile cavernoma. This is the pre-op MRI, post-op. Nice. And here it shows successful resection of the tactile cavernoma. The patient had an uneventful course and returned to preoperative baseline cognition and activity. However, he had upward gaze palsy and bilateral limitation of lateral gaze. This is the operation, this is the team, and this was in King Abdulla University Hospital. The follow-up MRI showed successful resection. 12 weeks later, the patient showed significant improvement with better upward gazing and nearly no squint. So the literature review showed 25 reported cases with almost equal male to female ratio. The most common chief complaint was a headache. Other chief complaints were altered level of consciousness and double vision. 60% of the reported cases had 2 or more hemorrhagic episodes. Most of the cases, 15 out of 19 who underwent surgical resection, demonstrated a gradual improvement until full recovery. Minimal post-operative morbidities were present. 4 patients died of this tactile cavernoma, and 6 patients did not undergo surgical resection. And no post-operative mortality case was ever documented. Next. The outcomes depended on the lesion size and the surgical resection. Larger lesions are more likely to lead to persistent deficits. So the surgical resection is the ultimate management modality, since most surgically resected patients or cases end up with complete recovery. Our conclusion was solitary tactile cavernomas are a rare form of brainstem cavernomas. The most common complication is the hemorrhage. Perinode syndrome is found in some cases with male predominance. This is the neurosurgery team, and I would like to shout out Dr. He's the founder, he's standing on a chair, and he's the founder of Neuropedia, and Dr. Muhammad al-Barbarawi and the whole team. Thank you.
راح يكون في تقييم لكل محاضر من الطلبة عن طريق انه تدخل على QR كود راح نعرضه حاليا، وبتقيمه من 10 بناء على البرزنتيشن اللي قدمه كل طالب.
دكتور فايز اوت اوف ذا ريكورد، يعني مش مشغول. مش لك جائزه تقديريه. طب احنا نظبط ابو العدد. طبعا في تقييم كمان للمودريتورز، وحيكون at the end of the day will be a reward for the best talk from students or moderators. وأنا من هنا بحكي الدكتور فايز، يعني أنا يوم أنا مش حدا في حدا.
Our next speaker is a 6th-year student, دكتور عامر from معهد من جامعة. He is welcome. عامر بلغات.
ما كنت بالعالم. ما كنت بالعالم بالتأكيد. دايما أعرف واحد الدنيا.
رجاء من الطلبة عدم الخروج من المحاضرات.
مين النكست سبيكر؟ بعدها مؤسس.
مرحبا، يعطيكم العافيه. انا طالب، اولا انا اعرف عن نفسي، انا طالب طب من جامعه مؤسس سنه ثالثه. اسمي عامر عدنان فرغاصي. واحده من واحده من احلامي انه
keep silent please.
واحده من احلامي اني صراحه اصبح طبيب، خاصه كارديولوجيست، هذا المؤتمر واحده من الفرص اللي ممكن اني ابدع وممكن اني يعني اطور نفسي كطبيب، وان شاء الله بعجبكم اول عمل لي.
ان شاء الله. نتمنى لك التوفيق.
Okay, I will start with English. Okay, first of all, the presentation that I'm trying to present is basically an unusual case of epidural hematoma. Okay, so like why to report this case? Like why to report something that is so common, epidural hematoma? Now, in this case that I'm going to present, we have actually like an unusual presentation. This is the first reason. The second reason is that this is a presentation that we'll talk about. First of all, there's no known agreement whether like what is the optimum treatment, and second of all, even if we use the treatment, there is no optimum prognosis. Okay. Now, moving to the introduction. Now, of course, like just like in general thing, what is epidural hematoma? You know, actually we understand that the meninges we have like 3 layers: urimeter, arachnoid, and as we know, of course, that the epidural hematoma, we have like a bleeding within the space that is just above that urimeter, okay? And that's in general, of course. Now, like, okay, now we understand that we have 2 types, from the textbook that I've read, we have 2 types for the epidural hematoma. The more common one is actually the traumatic epidural hematoma, but we have the less common one, which is basically the traumatic. The non-traumatic is not really our topic here. The traumatic hematoma that we will talk about is still common, but we have a representation of this one, okay? Now, of course, like there will be like a trauma. After the trauma occurs, the classical presentation, first of all, the classical presentation, okay? That what will happen, basically there will be a trauma, then there will be like a deterioration, okay? Then that deterioration, after that the patient will wake up, okay? Now, or like retrieve some sort of neurologic function and behavioral function. Now, from that time, okay, until the deterioration of the neurologic function later, okay, this is called the lucid interval, okay? This is the classic presentation, but this is not the most common one. Now, the more common, according to what I've read, is that there will be a trauma. After the trauma, there will be no lucid interval, okay? But like what will happen after the trauma, there will be immediate deterioration, like acute deterioration of the neurologic function, okay? Now, in the case that I will talk about, just a general idea, of course, the unusual presentation here is that after the patient had the trauma, there's nothing happened. The patient did not feel anything, okay? But after 2 to 3 days, he started to feel a gradual pain or hit, okay? But an immediate, gradually, like after the passing of the day, from day 2 to day 3 to the day 4, and until the end of the month, until we have reached like the 30 days, the headache started to bother the patient, and that's why he came to the medical attention, to the hospital, of course. And after he came there, he started to feel headache. So, and that raised the suspicion for the doctors. They, of course, did, according to the guidelines, they did the imaging. They did, in that case, of course, the non-contrast CT scan of the head, which is like the first thing in modality if you suspect any kind of a traumatic injury. And basically, they did that imaging and they have discovered that there is like an epidural hematoma. To be honest, it's more like a story more than reading from a slide. Now, of course, like I will just to present the age. The article presents, of course, of epidural hematoma, 15 years old. So the patient was 15 years old, male patient. He was like swimming. As I said, like I actually explained that 15-year-old male patient was presented to the emergency department complaining of headache that started 1 month before administration and was gradually increasing in severity. Now that's actually talked about. Of course, there's like association of other symptoms. Of course, along with the headache, gradually throughout the days, the patient started to feel, oh, I'm going to vomit. He did not vomit a lot, but he basically vomited 2 to 3 times throughout the 30 days, of course. Now, we did, of course, a complete physical examination, which is completely important, of course. Now, the physical examination, we did, of course, the most important thing. We, evaluated the level of the consciousness of the patient by using the Glasgow scale. It was actually normal. It was monitored within the department. Of course, like the TOO, like consciousness. And we actually measured, we did actually a complete neurological examination from like the movement. We even like did evaluated the muscle strength, whether there's like reflexes or not reflexes. And of course the vital signs was normal. And of course that's something that's important regarding the skull fractures. In epidural hematoma, like I've read that 85% of the cases there's associated skull fracture size. Basically, if there's like leakage of the fluid from the nose, rhinorrhea, if there's like a leakage of fluid from the ear, otorrhea, or if there's like button side, if there's like any kind of blood behind the ear, for example, or coon eyes. So there's nothing like that in the patient's form, to be honest. Okay. Now, speaking about the finding, as I said before, like once the patient comes, we have the suspicion, which is hard to be honest, and after that we do like, okay, we can do according to the guidelines. We do the imaging, non-contrast CT scan of the head, and we have seen like typical appearance of epidural hematoma. That's how we diagnose the individual case, and this is something that is special. As I actually I've written, and I will show you the pictures, that a typical finding of right frontal parietal epidural hematoma with a mass effect, which is a hematoma that is biconvex in shape, sharply demarcated, extra-axial lesion, hyperdense in appearance, which indicates that it's an acute one, and limited by future lines. And there is no associated skull fracture. Now regarding the pictures, now this is the first picture that is it was found within the hospital system, and this is the first image. The second image will be even like it will even be more evident. Here's like the typical appearance of the epidural hematoma. That's how we take in medical school. Like this is a question they bring the picture and they did what is that. Okay. After that, regarding the treatment. Now, of course, like as I told you, like what the first thing that is special about this case, the unusual presentation. The second thing that is why do we have to report this case is actually the treatment. We have like it's really unknown, or we have limited knowledge. Say that whether that what is the proper treatment for the epidural hematoma? That's true. Like most of you will say, oh, epidural hematoma, that's a medical emergency, go for surgery. Actually, I've read there is a conservative management for this case. If the patient doesn't have a neurological function, it doesn't have a neurological deterioration, which can happen in some cases, and the glaucoma scale is normal, there's no deterioration of the consciousness, you can put him like in the ICU, monitor the patient, and if the patient like doesn't have deterioration, then why go for surgery? Why go for the risk of the surgery? You just monitor the patient and everything will be normal, right? So this is the first thing. So we have to consider that as we doctors are trying to provide optimal treatment for this case. This is the first thing, the optimum treatment. The third thing is the optimum prognosis. Now, in this case, the treatment that was used in the Bashir Hospital, because, like as we know, we don't want to get into the risks and, we don't want to fear the patient. So basically, they used surgical evacuation. They used surgical evacuation and ligation of the rupture of the blood vessels. And that is the first line of treatment for the epidural hematoma in most of the cases. Now, of course, like after they have done the surgery, they actually followed up the patient. The post-op follow-up went smoothly, 5 days observation in the ICU, and then transferred to the floor, and everything was normal. After that, he was charged. So like the last thing that I wanted to say is that now the prognosis. Now, actually, we've done that surgical treatment, But we didn't really know, like until now, we didn't really know. Maybe there's like in the future, there's going to be like a effect about patient psychiatrical health, the behavior. We don't know, like after the surgery, maybe there can be a change in the behavior. There can be a change in the psychiatry. Maybe there's like an increased risk for some kind of psychiatric disorders, right? So yeah, we don't know that. So there's a need like there's like a need or requirement to study that, to be honest. Now, regarding the conclusion, I've said it many times, so there is no need. And thank you. Hopefully.
Thank you very much. أعتقد بكونك طالب ستودنت ما دخلت بالمراحل السريرية وما دخلت بالنيوروسيرجري براكتس يعني this is a very excellent presentation. أعمل بعض الكومنتس وأسأل رأي الزملاء في هذه الحالة. يعني في شيء اسمه spontaneous epidural hematoma أو subdural hematoma. As you know, the most common is trauma. There is either trivial trauma or severe trauma, significant trauma, but in certain cases there is no absolutely history of trauma at all. ولكن في مثل هاي الحالات لما يجي لنا مريض عنده spontaneous epidural or subdural hematoma، وين الطالب خليه ما يصير يكون لازم يضلك على الستيج حتى نخلص التعليم. Those patients must have angiogram to look for vascular malformation. Okay? ممكن تكون dural AVM أو sinuses AVM أو intracranial vascular malformation. لذلك the message for the student and the attendee or students, any patient with spontaneous epidural or subdural hematoma must have angiogram. الآن the second comment with regards to the surgical treatment and criteria to go for surgery even if the patient is asymptomatic because medical legal this patient deteriorates, we shoulder the responsibilities. لذلك إذا كان size of hematoma more than 1 centimeter on the CT scan, we go for surgery. وبالتالي الليترشر واضحة this regards to go or not to go for surgery. Less than 1 centimeter we don't go for surgery. More than 1 centimeter it's better to go for surgical intervention. شو رأيك دكتور فايز؟ عبد الرحمن أبو جاموس.
We published the morning paper to tell especially late presentation. Most of the late presentation acute hematoma usually it is made venously rather than arterially. And these of the patient was 15 or 14 cancer. And we published more than one another and one together. So the most important issue is close observation. It should be, and the theater should be ready anytime we may do an interface. However, most of the
There is a debate يعني واحد أي دكتور فايز بيحكي أنا أي go for surgery أنا مش بقول أي فبالتالي مثل هيك asymptomatic cases might be debatable well depends on the patient's condition and surgeon's experience. Okay, let's go for the next. Sorry آسف تفضل عبد الرحمن آسف.
بس بتذكروا إذا بتكتب الكيس في concept اسمه chronic extraocular hematoma. Chronic extraocular hematoma can present على قطعة 3 days يناسب يقطع 1 week. Could be, but this case is most likely venous one without significant, but nothing peculiar in this case. We see many cases in this. If the student revised their case with his consultant, I don't know, and what is the peculiar in this case. We see around 10 to 20%, 10 to 50% of extraocular late presentation. What's new in this case? You should ask yourself this.
Absolutely.
What's new in this case?
Another comment for the students كونه ذكر على اللوسيد انترفال اللي هي بنسميها فترة الصفاء أو فترة النقاهة. This is the typical representation in 10 to 30%. يعني more than 70% they present with rapid deterioration in conscious level. أما typical representation in lucid interval no more than يعني 1/4 to 1/3 of cases. فالهيستوري تبعته بياخذ ضربة على راسه بسكر او بصير عنده برين كونكشن بصير ارتجاج دماغي فبيفقد الوعي، بعدين بصحصح الزلمه او الفتاه وبصير ذهنه صافي برجع طبيعي، بعدين بصير في هاي الفتره الاكوميليشن وبديورال هيماتوما، وبالتالي يحدث الديتيريوريشن ان كونشس ليفل. لذلك ممكن يجي لك المريض يكون فولي كونشس في مرحله اللوسيد انترفال، وبالتالي في مثل he might end with a death. وللاسف صارت عندنا في بعض الحالات مش عندنا بالملك المؤسس وانما في الاردن او في العالم. طيب let's move to the next speaker. الشيخ الدكتور مؤسس عبدالله. One of our graduates graduated from Jordan University just يعني، وبعدين he obtained the higher specialization in neurosurgery. obtained يعني شو سموها زمان البريطانية Royal College of Surgeons Neurosurgeons of Britain. وupon his return يعني he's appointed at King Hussein Cancer Center. He's done lots of complex cases with excellent results. Actually, we are proud of our graduates who are doing great jobs across the country.
Thank you, Dr. Muhammad. It's a pleasure to be here. This is a very great opportunity for medical students to have all of this knowledge condensed in 3 days. What we will be discussing today is MRI tractography. This is a new evolving field, and I think it's becoming standard in all neuro-oncology cases. The thing to grasp from this lecture that will be presented by my fellow Dr. Marji is to know that there is something called tractography. It's becoming a standard in neuro-oncology. Alhamdulillah, in Markaz al-Hussein we can do tractography for all the neuro-oncology cases with good results. The second thing to understand is to know that Vernix and Broca's areas, the thing that you all read about and learned in medical schools is now becoming obsolete, and you will understand how the new model of ventral and dorsal tracts is becoming the new knowledge. I will leave you to listen to Dr. Ala and enjoy.
Just to introduce Dr. Ala, he is the same our graduated أعتقد من مؤتمر University. بعدين لما كان شوي مميز we accepted him فقبلنا فيه يتدرب عندنا. فgraduated وتدرب عندنا وكان outstanding دكتور، وهذا he's working مع الدكتور وليد دباس بالنيورون كلينكس وبكينج حسين ميديكال سنتر as a fellow in the neuro-oncology. we are proud of him to be with us. أهلا وسهلا دكتور.
Talk today about MRI tractography in brain tumors and how we implicate this new technology in our strategy planning. So I will give you a question and you will have the answer at the end of the lecture that why white matter matters for us. So next. Now our daily morning pre-operative negotiations, me and Dr. Moses, is what will be the plan for our battle today? How we will fight our enemy, that tumor? What are the plans that we have? Okay, so he always puts our plans, and he is like a military. He decides where to go, and finally I trust him. Okay. Now, what is DTI and what is tractography? DTI means diffusion tensor imaging. It is an MRI technique that uses an isotropic diffusion to estimate the axonal white matter organization of the brain. Okay, and it is proposed by one who is called Peter Basser in 1994. Now, what does this mean? If you are lazy, I will explain it in a simple way. You have the axons and you have water molecules inside it. So you know that every water molecule have Brownian motion, and the diffusion images makes control of this Brownian motion and then measures it. So if you have an axon, the water will pass through the axon itself. So we have slow diffusion across the axon, but faster diffusion through the axon. This will be translated into an image. And if you like mathematics, it is measured like this by directions, and they have multiple complex calculations to know what color they will give for each water molecule or each track, and this will be translated into an image. So we have a DTI image, and then it will be reflected into what is called fiber tractography. So it is the 3D reconstruction of what we have in the DTI. So we have two images. The DTI is the raw image, and then we make 3D reconstruction to have the fibers in it. So now we'll do some tracks review. Maybe you have here some of them in your neuroanatomy. First of all, you need to remember that tracks are divided into three groups. There are association, projection, and commissural fibers. Okay. These are some types of fibers that we know, or we are newly discovering in this new emerging field. We'll talk about some of them. Association fibers, like earthquake fibers. These are major components of the dorsal language stream, and it contributes to perisalvian frontotemporal pathway, which consists of long direct and short indirect pathways. It looks like this if you want to reconstruct it. The next one is the cingulum. The cingulum is a bundle that is principal white matter tract of the cingulate gyrus and the limbic system. It is involved with diverse range of functions like spanning emotions, behavioral and sensory motor control, mnemic processing, nociception, and executive functions. It is a bidirectional tract, by the way. You see it, okay? Now, we have one called FAT, or frontal ascending tract. It is a recently described one, and is an association bundle connecting the inferior and superior frontal lobe, and is involved in speech initiation, verbal fluency, and executive function, and inhibitory control. This is the FAT. Now, what is the importance of this one? We'll see in the next slide. You see how is the proximity of SMA area to precentral gyrus and the pre-SMA area. All of these are surrounded by this fibers. And the patient may have affection of mobility, not due to affection of motor strip, but due to SMA, what's called SMA syndrome. Now we have one of maybe the biggest fiber. It is called inferior fronto-occipital fasciculus, or IFOF, and it is a large, long-range association fiber bundle. It connects occipital, temporal lobes, and frontal lobes, specifically related to language, lingual posterior fasciculum, and cutaneous polar. Here you can see it. It is a big one, and it is related to our to many tumors that we face either in the frontal, parietal, or occipital lobes. We will see in the exams. Now here we can dissect it into many sub classifications. Every fiber here you can classify it in subfibers. Now on the right side, it is important for facial recognition functions and semantic visual stream processes. But on the left side, it is involved in semantic language functions. Then we have inferior longitudinal fasciculus. It is a large association tract also. It connects occipital and temporal lobes, and it plays important functional role in visual memory and emotional processing. You can see it here. Now, if you go from down to up, you have inferior liquidian fasciculus, then the middle liquidian fasciculus. It is also a larger association bundle, and it is hypothesized to play a role in language, visual, and auditory processing. It is a new information, maybe you are not familiar with this. Here is an image explaining this tract or fiber. Now, the superior liquidian fasciculus also it is subdivided into 1, 2, or 3, and some books divided into 4 parts. It is related also to language, visual, spatial thinking, and metacognitive functions, as you see here. Now we go to, for example, commissural fibers. Commissural fibers means that fibers play a role into both halves of the brain. So we have the anterior commissure, which crosses the midline anterior to the pre-commissural columns of the fornix above the basal forebrain, and below the medial ventral portion to the anterior limb of the internal capsule, as you see here. The corpus callosum is the largest fiber association fiber bundle in the human brain, as you know. Here's the fiber projection of corpus callosum. Okay. Now we go to projection fibers. If we want to talk about projection fibers, this means fibers that go from brain to the basal ganglia or to the spinal cord, like medial meniscus, and you see it here. Also the pyramidal tract, maybe the most important one that is involved in movement, in voluntary movement. As you know, it takes a wide area of the brain because it controls the function of all our skeletal muscles. Now, also we have optic radiations. You can see it here. So these are reconstruction of real patients, not like the Atlas books or the theory before. Now this is a reconstruction from real patients. Now you can see the importance of optic radiation in relation to the ventricle if you are going to do surgery involved with the ventricle. Now, have you studied vernix and Broca's area before? I think yes, right? But unfortunately, you don't need this information anymore. So discard this information. Now, there's no. This is obsolete. There's no Wernicke or Broca's area now. There's tracts. You always need to think for tracts, so that because maybe you have encountered patients that you can't give them a syndrome. This is a Broca syndrome. This is Wernicke syndrome, because usually they are a mixture of multiple tracts. So they have mixture of findings. Here we have a collection of the fibers together so that we see how complex is the topic. Now some real cases. You see here how we reconstruct the tumor, and we look at the fibers that surrounding it. Here you can see the cortex spinal tract, you can see the SLF fibers. Now, this is an illustration of fibers. You can see how important fiber tracking. If you are going to do the surgery without fiber tracking, maybe you think, yeah, the best approach is to go laterally directly to the lesion. But here, when you see that ILF is in front of you, you will change all your strategy planning. Here's another lesion, as you see, how close it is to the ILF. You see a small lesion, maybe you say, yeah, it's just a small lesion that you want to remove, the other one, but it's in a close proximity to the optic radiation, it may affect vision. Here, as you see, we can't predict where is the position of the motor strip and the sensory cortex before doing the tracts. It may fool you. Here's an example. You see how is the eye pop and cortex spinal tract are pushed by the tumor in their unusual anatomic location. Here's another one. You see that SLF is pushed down like this. Here you see how we have the SLF and the IFOC surrounded by the tumor. Now, usually they say that the left insula is not surgical area, and I have conflict with this thing even in my board exam, that you should not approach the insula. No, it is now a surgical area, and you can operate for the left insula. This is our patient. We operated last week, and he was discharged 2 days after the surgery without deficits. By using tractography and implementation of this strategic planning, you can avoid the deficits. Here is another patient. Maybe now you have seen all the pictures with the tracks, so you thought that it is easy, it is written. Now, if you have this patient and you are the doctor that you want to go for the surgery, you think maybe this enhancing area is amenable for surgery and you want to remove it, right? And you are keen to remove this small punctum there. But if you look here, all the motor strip is on the edge of the tumor. So you will enter in paralysis with the patient. Another case, here, maybe we can ask our residents, do you know where is the motor strip here? Maybe for residents, not students. Okay. Can you guess? Look now, where is the motor strip? It is pushed too anterior. You can't predict this before without having cartography. So this affects all your plan in your surgery. What area do you want to start? What area you may need residual in expense of having a good function post-op. Thank you.
Very interesting.
Any questions?
بس شوي يعني هذا التراكتوغرافي يعني هلا بتعرف تطور جراحة الأعصاب بالسي تي وبعدين MRI. هلا النيو ادفانسز in the neurosurgery practice is the tractography، يعني ما بيعملوا العملية إلا بوجود التوموغرافي أو التراكتس. للأسف يعني احنا وي ار براود انه موجودة هاي في الأردن في مركز الحسين للسرطان و they are in this subject more advanced than us in here at عبدالله يعني University Hospital. فأعتقد they are very lucky to have this أنه تقلل من المضاعفات والمشاكل وتحسن الاوتكم. Questions؟ دكتور فايز تفضل.
Diagnosed as a brain concussion, treated MRI normal, CT scan normal, and the result of the day they must have a must to diffuse this syringe to locate if there is any mountains or any associated fibers in it. So in trauma, especially in case of diagnosed as a concussion or normal brain MRI. So diffuse this syringe is very
ممتاز. أنا أعتقد إنه جاموس لازم هذا ندخل هاي السير بس يعني هاي نكست ستيب. We have to add. يا سيدي كذا تفضل دكتور عبد الرحمن. لأنه التوبيك جديد وأدفانس فيعني very interested إنه يعني نسمع أكبر قدر بس هذا حيكون على حساب استراحتكم.
We have been for years in the Florida University Hospital, so we do it and we have the software. But I think there's software. Yeah, we have.
صديقي بتعملوا ولا ما بتعملوا؟ هذا السؤال yes or no. إذا yes خلاص معناته أنا sorry معناته بالجواب الإنجليزي.
I mean their software is running also apart.
It's dynamic.
So my question, I have a comment regarding what Dr. said.
لو سمحتوا صوت you must respect the speaker please.
The fusion attenuated images for the brain compression or fuse absorbed image. But actually we don't use it for the trauma patient, this DTI. We use it, we use the fusion editing. The second point I'm asking Dr. Monis and Dr. Ala, did you use it for tractography for facial nerve, cranial nerve, especially in vestibular phenome? I have experience in Sweden. We do it for facial nerve to locate facial nerve before entry in the vestibular phenome. Yes, thank you. We are using an integrated system now. We are using an integrated system now for the vestibular phenome. So you have got the intraocular monitoring for facial nerve PSD. But then, as you see, you have got the software that you can basically plan how any how many days the visual numbers, well, not as much as you do, but we are doing it for all of these. So you can see the facial nerve relationship. It should be a practice in this case to decrease the mortality and morbidity.
ممتاز. عندي كويستشن from the students. سوري تفضل دكتور بعدين نخلي واحد من الطلاب.
I think these things sound like fantasies and they develop then it becomes like standard of care as Dr. Faiz mentioned. And my question, do you have any combination with the spectroscopy with this with spectrography?
Spectroscopy is mainly for diagnosis rather than for
treatment.
Planning surgery. So it's very unlikely that you use spectroscopy unless the result is really not happy.
Do you have the facility?
We do have functional MRI, we do have spectroscopy.
ممتاز. يعني الفكره او المسج للطلاب او الفيوتشر دكتورز انه التطور اللي صار الان واحنا وي هاف ات ان جوردن. هلا احنا بنعمل MRI بنعمل انجيوجرام بنعمل فبنحط ال 3 دي ان اور مايند لما نيجي نعمل الابروتش كيف نعمل البوزيشن كيف ندخل شو الاشياء اللي ممكن تواجهنا. فذيس يعني انترنال 3 دي وهي سبجكتيف. أما ما يعمل الآن بالنسبة للنيورو انكولوجي إنه they have the tomography in front of their face when they operate on the patient. يعني ما في داعي يقعد يفكر ويقعد مباشرة بيعرف وين بده يروح وكيف يروح والليمتس تبعته. وهي أهم شيء إنه he knows his limits during the operation وبالتالي he doesn't add harms for the patient. الآن إذا بتسمحوا لنا نكرم السبيكرز. أما بالنسبة للطلاب إن شاء الله حيكون تكريمهم في الجالا دينر الذي سيعقد في عبدون في مطعم في عبدون الساعة 7. فالجميع طبعا مدعوش الدكتور. فالتكريم الآن حيكون للأخصائيين. أما الطلاب سيتم تكريمهم مساء بعد ما نشوف شو البيست سبيكر أو البيست توك بحيث يتم التكريم على عدة الأصعدة. فأول سبيكر كان الأستاذ الدكتور عبد الرحمن اشتفات. الدكتور طه جان بيك. دكتور طه جان بيك. السريع. إن شاء الله يعني الآن هيكون بريك for 10 minutes please.